Hello everybody, I'm Dr. Srinivas Jalluri, Director of Surgical Oncology, Medical Cancer Institute. So today we'll be discussing about surgical treatment of bladder cancers. Bladder cancer surgical is divided into two types of diseases. One is non-invasive superficial bladder cancer, other one is invasive, deep invasive bladder cancer. Now superficial cancers are the commonest ones. Literally 80% to 90% of bladder cancer are superficially invasive. Superficially non-invasive bladder cancers. Most of these patients present pretty early in their 40s and 50s. They usually present with hematuria, and on investigation they don't have any invasion, but they have surface nodules which are like polypoidal growths. So something like sea anemones and those kind of things. So these are tumors which are managed endoscopically only. So we do what is called a cystoscopy and fulguration or cystoscopic resections. They're called transurethral resection of bladder tumor. They don't require any cuts, they don't require any surgical interventions of a deeper kind. So they're very non-invasive procedures. Most of them are daycare procedures. They get surgery in the morning and they go back home in the evening. But unfortunately, a large number of these patients do come back with a recurrence in the future. The recurrence could be in early grade tumors, it could be like several years later. In high grade tumors, it could be much earlier also. So all these patients are put under strict surveillance. Every patient with superficial bladder tumor, in spite of treating and curing it, is a likely candidate for coming back with recurrence. So everybody is supposed to be on a proper follow protocol. Apart from this thing, so those patients who have this higher tendency to recur, those patients are offered what are called intravesical therapies. So apart from surgery, we also do what is called installation of medicines into the bladder. We use mostly TB bacilli, so BCG is what we use. It induces kind of immunotherapy. It's a kind of one of the first forms of immunotherapy that is used by medical science is actually the BCG installation for superficial bladder cancers. So this basically induces an immune response by the patient's body and develops a kind of resistance to these tumors coming back. But unfortunately, this is not a permanent immunity. So those patients who are continuously exposed to the risk factors like what Dr. Sadhvik has mentioned, smoking and exposure to chemicals and things like that, they do come back to us with recurrence. Now, some of these recurrences and some of these de novo patients who just come to us with a more deeper disease, they're labeled as invasive bladder cancers. Now, invasive bladder cancers can be urothelial cancers, adenocarcinomas, or they could be squamous cell carcinomas. Depending on the type of cancer that we are looking at, we offer them treatment. Now, as you know, in the modern days oncology practices, we always try to preserve the organ. That has become the kind of mantra of modern day oncology practice. So, in this regard, we have a comprehensive cancer protocols that we prepare. We discuss these cases in the tumor boards and then have a plan of action. So how do we preserve the organ? So those tumors which are small and treatable with radiation and chemotherapy, they are offered that one. So they avoid a surgery. They avoid a major surgical procedure for that one. So that is how we achieve what is called the organ preservation of these bladder cancer patients. But not everybody is suitable for organ preservation. So like those patients with a deeply invasive tumor, those patients who have invasion into the bladder fat around the bladder, those patients who already have extensive nodal diseases, not everybody is suitable for organ preservation. So those patients with these extensive diseases, they will go for what is called a cystoprostatectomy or a radical cystectomy and a uretrectomy, depending on the location of the tumor. Now, like it is happening with every other organ in the body, even for a bladder, where organ preservation is not possible, we always try to do functional preservation. Now, what is the function of the bladder? Store the urine and let it be excreted. So to achieve this particular process in those patients who are young enough, in those patients who are fit enough, we can do what is called a nerve-preserving cystoprostatectomy followed by neobladder creation. What do you mean by neobladder? A new bladder is created by the body's own tissues. Now we commonly use the small intestine. Sometimes we can use a large intestine in those patients who have got a big, large intestine, sigmoid colon. We can use that one. And we create a pouch out of this particular thing, and we implant the ureters from both the kidneys into this pouch, and then we attach it to the urethra for the outside flow. So the patient has got nothing like a bag or anything to collect the urine. So this patient goes around with like anybody of us. We'll be able to get a pass urine in majority of the patients. Some patients, when they're old, when their nerves are not that good, when they have a big extensive disease, like it happens in around 10 to 20% patients, they will not be able to void by themselves. They will not be able to pass urine all by themselves like normal people. But they can be assisted with a passage of a small catheter 3 to 4 times per day. That is called clean intermittent self-catheterization. This is something which can be taught to every patient who undergoes a surgical procedure. And it's a very simple thing that they can travel around, they can do it in a small place, and they can comfortably do that one and have a near normal life. Now, apart from those patients who are suitable for organ preservation and functional preservation, there will be a set of people whom we cannot preserve the organ, and at the same time we cannot create a normal pouch, normal new bladder. In those patients, there are again two options. In those patients who are suitable enough, we can do what is called a continent pouch creation, whereupon there is a bag that is created inside. The ureters are put into the bag that we have created, but they do not have a normal passage. For some reason, we had to remove the normal passage, maybe because there is cancer in the passage itself. It can happen. So urethra itself can develop the same kind of cancer that bladder develops. So in those patients, we have to remove the urethra. So when you have no normal passage, you cannot create a new one completely. In those patients, we create what is called a continent pouch. It doesn't leak. There is no leakage of urine outside, so they don't need to wear a bag and go around. So these patients also will require what is called a clean intermittent self-catheterization, which means timely, every 6 hours or every 8 hours, they have to kind of empty the bladder. They will have sensation. They know when the bladder is getting full, this new bladder is getting full. Then they will be able to do the CISC. Now, apart from this set of patients, unfortunately, bladder cancer is one of those tumors which happens to be more common in elderly people. Now, elderly people, as you know, can be having diabetes, hypertension, chronic morbidities. They may be feeble enough not to be able to kind of do these things by themselves. In those patients who cannot take care of themselves, like round the clock kind of a thing, those patients who do not have the hand-eye coordination, then we cannot let them do clean intermittent catheterization, things like that. In those patients, we create what is called an ileal conduit or a reimplantation into the sigmoid colon. Now, most of the patients will be going for an ileal conduit. The reason being, what do you mean by ileal conduit? We use a small segment of small intestine, we separate it from the small intestine, and then we bring it out like a small tube outside, and then put the urethras into the ileal conduit. These are the people who will have to wear a bag permanently. Now they will have to kind of empty it regularly so that they don't stink and they don't leak and things like that. There's an amount of care that is required for all these patients. Still, they can have a normal life, which basically means they can travel, they can do their jobs, they can ride bicycles, they can ride cycles, they can ride cars, which basically means they're near normally functioning like anybody else, except that they will have to take care of the stoma. Now, why do we need to take care of the stoma? Because this urine is a thing that comes out of the body, which is a culture medium. So if you don't take care of the urinary bag properly, they can get recurrent infections. To avoid the recurrent infections and to avoid unnecessary damage to the kidneys, they have to take care of them. All these things are kind of taught to the patients. They usually take about 2 to 3 weeks to learn these things, and then once they are learned, they do extremely well. So we usually don't see patients coming back with issues of self-care. So that is how we plan the surgical treatment, basically the treatment of urinary bladder cancer itself. Where possible, we always try to preserve the organ, avoid surgery. Where it's not possible, we always try to do what is called a functional preservation surgery. So in those patients, which basically happens to be about 20 to 30% of the patients, where there is no choice but to do complete resection with reconstruction, there we do what is called a radical cystectomy with ileal conduit. All these things are to be discussed with individual patient. Each patient is new, each patient is specifically different from the other patients. So these discussions are always individualist. Don't go by what was done to another patient that you know of. So what is going to be done to you is totally different from what is being done to somebody else. So please do come to us and discuss in detail with us. Then we can have a best plan of action for you. Thank you.